TopMedTalk.
Welcome to TopMedTalk's annual digest. This is part 2 of a 2-part programme, covering some of the most listened to pieces we've done over the last 12 months. We'd love you to check out part 1 if you've not yet heard it, but it's not essential for you to enjoy this programme. TopMedTalk, if you've never heard us before, provides free medical information for high-level practitioners and students each week. Make sure you register on whichever podcasting platform you've found us on, because a like and a subscribe review now helps us reach more people in the future. Coming up, we're going to be listening to Ross Kerridge, the father of perioperative medicine. Also, we're going to be listening to a podcast that concerns the evolution of the impeller device in anesthesia, critical care and perioperative medicine. Also, is trauma-informed care part of your perioperative process? And we're looking at the ROCKET trial, investigating the use of ketamine to prevent chronic post-surgical pain, and PANDOS, which stands for pain and opioids after surgery. But first, we're looking at patient safety and quality, new standards in anesthesia. And it's a podcast that we did from Anesthesiology 2024, the annual gathering of the American Society of Anesthesiologists. Dr. Jonathan Cohen, a board-certified anesthesiologist with a focus on patient safety, shares his journey. The conversation covers the continuous need for innovation in safety practices.
You know, there is no finish line when you're talking about safety. Every day has its own threats. Unlike other high-reliability organizations in fields like aviation, our patients are all different. You'd never get into the habit. It's not just flying one plane every single day that's assembled the same way. Patients are different. Their preferences and options for treatment that they select are different. So there's a lot of uncertainty and variability that exist. We're constantly coming up with new ways of doing things. Paul Virgili said a long time ago, when you invent the ship, you invent the shipwreck. So whenever we're inventing something new, there's a lot of innovation in anesthesia and healthcare in general. We also need to pay attention to the innovation for solving the problems that these new methods of doing things create that were unanticipated at the time that they were created.
We also discussed the role of organisations like the Anesthesia Patient Safety Foundation, APSF, and the Institute for Healthcare Improvement, IHI, in promoting safety and quality in healthcare.
Safety needs to be something that's front and center for everybody. There are a lot of great resources through the Anesthesia Patient Safety Foundation and more to come soon.
Yeah, and remind me your role in the APS.
Just recently, I became co-chair of the Patient Safety Priorities Group for Culture, Teamwork, and Provider Wellness.
Wow.
So we're looking to re-kick that off soon. It's a merger of originally 3 different categories that's now in one, and then see what we can do to improve that.
Yeah, that's great. Well, we'll keep an eye out for that.
The episode concludes with a discussion on the importance of certifications and the dissemination of safety strategies in improving patient outcomes globally.
Safety becomes the purpose through which the other elements are then achieved to yield quality care.
Yeah. The APSF newsletter that was out here in June of 2024, Why Should I Obtain the Certified Professional in Patient Safety Credential? So why should we do that as Team Anesthesia?
I think it establishes kind of a benchmark for what are the important things to know in patient safety. And then it measures that in people who take the exam to make sure that they have this level of competency. And then in maintaining the certification, ensures that you're keeping up to date. Because again, just like anesthesia, things change over time. Some of the things that we're doing with safety now, we weren't doing 5 years ago. So it's important to keep active and keep up with the changing face of safety so that we're doing the most current things.
It's a wide-ranging conversation, and it's proved to be very popular here on TopMedTalk. We can't do it justice in clip form only, so make a date with the full episode and find the details of it in the show notes to this podcast. Moving on now to a very popular piece called ROCKET Trial and PANDOS, recorded at Euroanaesthesia 2024. Patrice Forget and Philip Payton share insights on their groundbreaking research projects. Let's have a listen first of all to Patrice, Professor, Clinical Chair in Anesthesia at the University of Aberdeen and Honorary Consultant at the NHS Grampian, Chair of the PANDOS, Pain and Opioids After Surgery Research Group.
We're going to include 20 countries, not 10. Because the enthusiasm is there. People just get back to us and to the trial coordinate a coordination team. So we just accept as many centers as may come, and the study is still open for new centers. That's important because the opioid crisis might be to some extent an opioid epidemic. For instance, in my center, I have to deal with a number of people with problematic opioid use. In other countries, it might be an inadequate access to opioids. So a crisis may not cover necessarily the same. Probably for some people it's different. At different time, we may have to be reactive to patient needs, to prescribe opioids when useful, to deprescribe, to taper, to support people in pain.
Desiree, it really ties into what you're experiencing in the United States. And in fact, the United States, not making a joke here, is actually a collection of different communities who are very diverse. And Patrice could go global with a study or do. It reminds me a lot about ISOS and ASOS and those mortality studies that people did.
Yeah.
This is a really patient-centered.
The conversation continues, and Kate Leslie weighs in on the importance of a wider international approach to this issue.
The risk-benefit balance is positive. Clearly, then, the picture is much richer and patient-centered, and then we can work on that to have a rich agenda and as helpful as possible for these people.
I think it's going to be fascinating looking at the inter-country differences in PANDOS. We've done a lot of work in Australia and New Zealand establishing a program called Effective Pain Management, EBPOM, which is a program that's been run out in countries around the world where, in low-resource countries where people are very reluctant to use potent opioids, so it's got the opposite problem of patients with inadequately treated pain, and then probably virtually no post-operative pain management.
Our other guest discusses the ROCKET study investigating the use of ketamine to prevent chronic post-surgical pain. Philip Payton, now Head of Research in the Department of Anesthesia at Austin Health and Professorial Fellow in the Anesthesia, Perioperative and Pain Medicine Unit in Melbourne, Australia. Have a listen.
I guess I should preface my description by just pointing out, I think chronic post-surgical pain is a very significant part of the chronic pain problem in general, and the purpose of this trial, it's an exercise in primary prevention, basically. So we're investigating whether up to 3 days of perioperative ketamine, it's a double-blind, multi-centre randomised control trial, will influence the incidence and the severity of chronic pain at 3 months and 12 months post-operatively. So the definition of chronic post-surgical pain now under ICD-11 is pain that's persisting at 3 months post-operatively, and that's now our primary endpoint in the trial. The dose of ketamine we're trialling is very representative of what's commonly used in clinical practice. So it's an intraoperative bolus, an intraoperative infusion, and then up to 3 days of post-operative IV ketamine.
The conversation highlights the patient-centered approach. Our host, Desiree Chappell.
The pendulum has swung the other way, and so it's very difficult to get a prescription for post-op opioids, and what we use in the OR is very different than what we used even 10 years ago. So I think this is very appropriate. There's an opportunity for sure for people from all over to be able to participate in that. One of the things I also wanted to mention as I was listening to you and Philip, you said you're a pain specialist, and there are a lot of people, but most of us as an anesthetist practicing, we all have to be specialists to some degree because that's mostly what we do, pain management. So having these studies to inform what the clinician, an average clinician, can do is very important.
It's a fascinating conversation. Well worth listening. Links to it in the show notes. Now, here's a question for you. Is trauma-informed care part of your perioperative process? In this episode of TopMedTalk, host Desiree Chappell speaks with Dr. Tracy Vogel, expert in trauma-informed care within the field of obstetric anesthesia.
If we can learn to see these patients as symptomatic and not problematic, I think it helps us to say, okay, this is a trauma response, or they're really stressed. Maybe instead of me walking in there with my computer, I just pull up a chair next to them, be a human, and say, this can be a really stressful time. I get it. Is there anything that I can do for you right now in this moment just to help you catch your breath? and just give them a minute to calm down. It can be a very different start. And you sit down. Notice I said sit, because that's so important to get rid of that hierarchy, the physical hierarchy, with you standing above them. Even being in a gown can create a vulnerable space for these people. And you don't want to separate them from being able to get to the door. Never approach them from behind where you could startle them, especially if they're already agitated.
Dr. Vogel explains her journey from practicing as an obstetric anesthesiologist to establishing one of the only 2 trauma-informed perinatal clinics in the country. She discusses the impact of interpersonal trauma on patients and shares statistics highlighting the prevalence of trauma among women, especially in obstetrics.
Somewhere between 1/5 to 1/3 of all females will be the victims of childhood sexual trauma by the age of 18. And that is supported.
That's childhood trauma?
Yes, that's sexual trauma. And that is supported over and over again in the research. Wow. And we may be underestimating because so many people don't disclose. Okay, so think about that. If you extrapolate that number to how many are coming through childbirth or coming to the operating room for other procedures. So that's a very high number. I find it very profound. It's disturbing to me.
The conversation touches on the need for universal trauma precautions and the broader societal and clinical implications of unaddressed trauma, especially in relation to childbirth and post-operative care.
Trauma work needs to happen everywhere. Systems need to be trauma informed and working towards a healing-centered, trauma-responsive state. It's not just clinicians. And I work for an organization, volunteer for an organization in Pennsylvania called HEAL PA, and a governor-appointed task force with the hope of making the entire state trauma-informed. So it's
not obstetric,
just everything from education to law enforcement, child abuse centers. It's everything. But I chair the committee on the physical and behavioral health action team. So bringing trauma awareness and trauma-informed practices into healthcare in general, of all levels and all types. So yes, everyone needs to understand it. It's because trauma is so pervasive. It's really everywhere. We think at least 60% of our population will have experienced at least one traumatic event in their lifetime. Serious traumatic event.
Now, the American Society of Anesthesiologists annual general meeting again, Anesthesiology 2024. One of the pieces we did there proved to be very popular. It's called The Evolution of the Impeller Device in Anesthesia, Critical Care and Perioperative Medicine. Desiree Chappell, Monty Mython and Mike Grocott with their guest, Asad Usman, anesthesiologist, critical care specialist and physician with Penn Medicine in Pennsylvania.
We fly out maybe 60, 70 times a year for mobile ECMO for patients in and around the region. We've had patients all the way down from Florida come during COVID. And so I'm part of that team and manage patients who require cardiopulmonary support, typically with mechanical circulatory tools. And that's what I'm here to talk about today.
ECMO, extracorporeal membrane oxygenation, is a life support machine that temporarily replaces the heart and lungs function. The conversation continues as our guest explains the new impeller cardiac power device.
And I think the way the technology is going and the way that our skill set is going, given my expertise, you can see that there's many anesthesiologists, intensivists in Europe that deploy ECMO. Why can't we deploy an Impella CP if that's the better tool with the skill set that we have? We have all very good vascular access skills. We are taking care of patients in the ICU. And so, I think that's what the future is going to hold for those of us who practice in the ICU. Middle of the night, patient comes in with cardiogenic shock. You talk to your colleagues, heart failure colleagues. You talk to your surgeons and think about what tool to use. And that may be one of the tools you have in the armamentarium.
Yeah.
It feels to me as an old guy who's just stepped away from the bedside. You mentioned right at the beginning that hemodialysis on the intensive care unit was the first extracorporeal support. Now, I remember when that had 100% mortality rate and was only performed at very specialist centres. And now you wouldn't bat an eyelid by putting somebody on extracorporeal support for the kidney. Everyone does it, and everyone does it remarkably safely. It's not always perfect, but it's solved a lot of problems. It feels like we're making that sort of transition for the heart. What it feels like to all.
Yeah, I agree. I mean, I think the limitation is the size of the tool.
Yeah.
Finally, here on TopMedTalk, we're looking at a personal favourite of mine. Ross Kerridge, often described as the father of perioperative medicine, very generously gave us a full, long-form sit-down interview, and, as you'd expect, it's fascinating. Hosted by Andy Cumsty from the Evidence-Based Perioperative Medicine World Congress in London, our guest, Ross Kerridge, reflects on his 40-year journey in medicine. Kerridge shares emotional and inspirational experiences from his early days at Ealing Hospital in London and his later work in Sydney, discussing notable advancements in medical and surgical practices over the decades. Here's a snippet.
Well, just recapping what I said, it's interesting thinking about 40 years. Obviously, the world's changed, but hospitals have changed as well. Hospitals used to be, they weren't quite cottage hospitals, but they still to some extent had the atmosphere of a cottage hospital in that they were very small or smaller institutions with a great institutional loyalty and staff that had been there forever and that sort of thing, and dominated by some of the giant personalities, both medical and nursing, of that era, many of them from the great generation, you know, the people who had grown up in the 1930s and then served in the war, and some of their values. And sure, some of those values maybe don't fit with where we are today, but some of them are really valuable. And that has changed, and hospitals have merged and coalesced and are perhaps a little less friendly than they used to be. But on the other hand, we're much more efficient. And of course, what we're doing is just extraordinary. The amount of work that we're doing, and 40 years ago, when someone was over 60 and certainly over 70, they were almost seen as past the point of needing surgery or having surgery. And people in intensive care at that age thought they didn't have much of a chance, and indeed we wondered why we're bothering with these sorts of people. And dialysis wasn't readily available, and so things were much more in their infancy, particularly in intensive care.
Here's Ross on the transformation of HIV from a fatal condition to a manageable chronic disease with proper drug therapies, highlighting the complexity of coordinating treatments around surgery.
With HIV, which used to be a death sentence, and now they're on the therapies and they've got a full life. They're a routine patient. But the preparation for surgery and coordination of all the drug therapies around surgery is going to be an ongoing challenge. And I think the other thing that we should look at is the amount of data. That medicine used to be just a matter of dealing with the protoplasm of the patient. And over 500 years, we've defined the anatomy and physiology of the protoplasm and how it's divided into different organs and how it all works together and fits together. And I suppose, 150 years ago, psychiatry started dealing with the mind side of the mind-body divide and talking about all the different parts of the mind and the id and the ego and all those concepts. But now a lot of what we do is information. And in fact, we don't actually have to have the patient in front of us. We're just processing all that information, and yet we haven't got a standardized anatomy of what you might call the endoplasm. And if you're going to do it, the perioperative milieu would be the ideal place to do it, because we have patients coming in all the time and we're gathering a whole lot of data. And even in the modern EHRs, electronic health records, it's still not organised in a way that's intuitive, and that we've agreed that this is the way we'll present it, if you like, that we've defined the anatomy of the endoplasm.
Ross also speaks about the crucial importance of a data-driven approach.
You don't really need data it's such an obvious thing to do that why would you even bother doing the data? You just implement it. But I've since learned that that's not the way the world works. You do have to gather the data and you have to work on culture, and in fact the implementation of rapid response teams has been much more complex than I ever would have anticipated. That's why I'm not on the original paper, although they did acknowledge me in the tail end of it as that was my idea in the first place, which was nice. So
And again, we were just talking before we came on air, if you like, about the importance of data acquisition and shared data agreements. I think that follows on quite nicely from that story.
Yeah, you do need to have the data. It's not the only thing that you need. And you may remember one of the other points I made. People say, how do you get the money and how do you convince the finance people? And I think some clinicians fall into the trap of thinking, I just need to gather the data and present that to the finance people and they will see the wisdom of my ideas and fund them. And I think it's worth remembering that the finance people are people. I think clinicians sometimes are unwisely pejorative, talking about them as the bean counters and dehumanising them. And they are people whose skill and knowledge is in making financial decisions, but they are working in hospitals.
It's a highly worthwhile piece. Strongly recommend you find it in the show notes to this podcast, where you can find links to all of these conversations. Thanks for listening to TopMedTalk. Don't forget to subscribe. We have a new podcast out every week.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.